Department of Health daily COVID-19 briefing. Let's go ahead and listen in.
To Mike Schuler. Mike, the floor is yours.
Thank you for joining us for the COVID-19 media call for December 9th. We'll start today's call with some comments from Health Commissioner Jan Malcolm. We also have MDH Infectious Disease Director Chris Erzman on the line. We will open it up for questions, but first let's turn it over to Commissioner Malcolm.
Thanks, Mike, and good afternoon, everyone. I've mentioned a few times in recent days that just the enormous pace of growth in COVID-19, not only in the United States as a whole, but around the world. Pretty routinely now, over 500,000 cases every day around the world, and unfortunately over 10,000 deaths per day globally. Today's figures were 627,000 added COVID-19 cases around the entire world, and an increase of 12,386 deaths. In the U.S., we've begun to see, unfortunately, most days at or above 200,000 cases in a single day. And our number of deaths daily in the United States has been 1,000, 2,000 and higher each day. As of today, the United States has more than 15.1 million total COVID cases, an increase of 218,000 from the prior day, and an increase of 2,592 deaths. So again, just trying to put in context for folks that what is so challenging for us here in Minnesota is truly a national and worldwide crisis as well. In Minnesota, we have another 4,539 cases that we are reporting today on a total of just under 40,000 tests processed. That brings us to a total of 363,719 cases in Minnesota since the start of the pandemic that have been confirmed through laboratory tests. As we've said, unfortunately, we're on a pace to hit another 100,000 mile marker, and we'll probably be at 400,000 cases within the next week or so. I'm sorry to say we have another 82 deaths among our fellow Minnesotans that were reported to us yesterday that we're announcing today. Brings us to a new total of 4,000. Actually, I think that's not the right number. I'll have to get you a cumulative total of deaths in Minnesota. 82 additional deaths today, reporting today. 3/4 of those deaths were among people from greater Minnesota, and their ages ranged from people in their 40s through their 90s. 51 of these residents were long-term care facilities. Our hospital admissions remain quite high. We're still at over 30 weekly admissions per 100,000 population, and our ICU admissions remain near the highest levels that we have seen throughout the pandemic. We're glad to note that the new cases per 100,000 measure that we monitor in our public health risk scores that are posted on the web, that metric has continued to decline and is lower than it has been over the last 7 days. But however, just to remind us again how quickly cases have grown, where we are today, even though we're glad that we've seen a drop in the last couple of weeks, the rate of case growth per population is a full 60% higher than it was just a month ago. So again, just as we talk about most of these data just about every day, it's easy to kind of lose sight of the broader trends, but the really rapid increases in November were stunning, and the fact that we've seemed to have stabilized a bit in recent days is a really gratifying thing, but we still have to just recognize what a very high level of case growth and activity and hospital activity that we have. One thing that we do remain concerned about is the 7-day average testing positivity rate, which is still right around 13%. We had been glad to see that metric ticked below 12% briefly, but has now inched back up again. And that is, of course, one of the key ways that we get a handle on how much virus is circulating out there in the community, and telling us that there's more virus circulating than we are finding just through increased testing. And the availability of testing continues to be a very good thing with the number of semi-permanent sites that are now available around the state. So we just do want to keep encouraging people to get tested if they need a test, if they have any symptoms, if they have been told that they've had an exposure, or if they are concerned for any reason. I want to go back and just note that the cumulative death total, I believe, is over 4,100 now. Just wanted to correct that data point. Today, we really want to leave a lot of time for your questions, most of the time for questions, because we've had some pretty significant announcements the last couple of days, and particularly with yesterday's news of the first, what will be certainly a series of vaccine-related updates. So we will leave most of the time for your questions, but I just wanted to reiterate a few of the key points, some of the things that we've had some questions about since the briefing yesterday. And as we've said, it's just a really significant development to know that safe and effective vaccines do exist, have been developed, and are on the way to us. And we are all very eager to get to the other side of this pandemic with our friends and family safe and healthy, and for our economy and our schools to be able to be open and thriving. And we do believe that the vaccines coming to us are the critical tool that is going to allow that to happen. And as we've said yesterday, it's very important, though, that Minnesotans, while being rightly hopeful and optimistic about the shift in the pandemic that this represents, we need everyone to understand that two things, both that when the vaccine becomes available to you, getting the vaccine is one of the best things you can do to help get us out of the pandemic and get to those better days ahead. And we want folks to know that the vaccine is safe and effective, and will encourage people to get vaccinated when they are able to do so. That is a key way we're going to get COVID under control and get to the other side of this pandemic. But I do want to emphasize again that we are not mandating that people get the vaccine. As we've talked about, the federal government still hasn't given the final approval, and when they do, there are likely to be some conditions attached to that approval. But it's important for people to know that this vaccine is not mandated, but that we want people to have good, solid facts upon which to make their decisions about getting vaccinated. We will be encouraging people to get vaccinated because it's such a powerful tool. But we will continue to provide the best information that we have as we have it. So that is one question we wanted to quickly address is that this is not a mandated situation. We do want people to get vaccinated. We've also asked for a lot of patience on the part of Minnesotans. As we talked about, the volume of the vaccine is going to grow, and it will grow over the coming weeks and months. But in these early weeks and months, that volume is going to be quite constrained, and it's going to take us several weeks even to vaccinate the very, very highest priority subset of healthcare workers and people in long-term care that will get the first vaccines. It's going to take several weeks just to work through that population. So we used an analogy yesterday that I hope people found a little bit useful, that the vaccine is like a real, especially at a high level of efficacy as these first two vaccines have. These vaccines are a pretty powerful fire hose, in fighting the fire that is the pandemic, and they're going to be effective tools. But we know that the fire is quite large, and that we're not going to be able to put out the fire with the fire hose alone, and that the fire hose will be able to do its job the best if we can keep the size of the fire under containment, and if we all continue to do the things that we can to keep that fire from getting even further out of control. And the personal responsibility that we all have to help slow the spread of the pandemic and help that virus to be as effective as fast as possible to literally getting us to the other side of the pandemic is going to be just really, really critical. Just a few other points to underscore. We've been getting questions about whether the vaccine is recommended or not recommended for people with underlying health conditions. That's one of the things that we'll get more insight into that question when the FDA publishes the report and the data that will accompany the regulatory action, which we certainly expect that the FDA is going to grant that emergency use authorization. But some of the detail coming along with it will inform this question on impact of the vaccine and any potential counterindications for specific people. Also want to make clear that the federal government is going to be covering the cost of the COVID vaccine. This is part of the national response. The federal government is buying the vaccine from the manufacturers and will be distributing it to us. So this was going to be free for individuals. Those who are doing the vaccinating, the provider organizations that will be doing the actual administration of the vaccine, are able under the law to charge for a clinic visit or an administration fee for the vaccine, which we expect can be reimbursed through people's insurance or through, for people who aren't insured, the vaccine provider is able to file for reimbursement for that administration fee through the Health Resources and Service Administration's Provider Relief Fund. People getting the vaccine are likely to be asked for their insurance information for these purposes. But you should not be charged for the vaccine yourself. We've also been asked about how people will know when it's their turn to get the COVID vaccine and what do they need to do to sign up for it, so to speak. And the basic answer, as we've said, is that really all we're talking about right now, all that's going to be rolling out in the very next couple of weeks, are these phase 1A vaccines that are going to be used with healthcare workers and people who reside in skilled nursing facilities and assisted living facilities. And so because these are focused on specific settings where healthcare workers work or where people in these specific long-term care settings reside, the vaccines will be administered there at those sites. So nobody in the healthcare worker or long-term care resident category needs to wonder about those vaccines will be brought to people on site. And we will continue to let folks know about vaccine doses and availability for future phases and what that's going to look like, what that timing might be, and how to go about getting a vaccine in those later phases as we know more. But at this point in time, there's really nothing much more to say about that, about how and when those things will be made available. And I think we'll at this point just open it up for questions. We're interested to know what kind of questions you have or your listeners or readers have. So back to you, Mike.
Thank you, Commissioner. Operator, we're ready to take questions.
Thank you. And as a reminder, if you would like to ask a question, please press *1. First question comes from the line of Theo Keith of Fox 9. Your line is open.
Hi, I actually want to ask a couple of follow-up questions from the very last answers you gave at yesterday's news conference regarding information collection and sharing, and also the cards that people are going to be getting as proof of vaccine. In terms of the personal information that the state will collect but not share with the CDC, is the state collecting that information so that then a person would get a phone call in 3 or 4 weeks when it's time for dose number 2 to be given to them? And then in regards to the card that people will be getting, I'm wondering if MDH has gotten that request from private businesses or maybe sports venues, entertainment venues, as a way that someone could more easily gain access, to ensure that they've gotten the vaccine.
Jan, do you want me to go ahead with that?
Yes, please, Chris, thanks.
So you know what, Theo, I just realized I say the first part of your question was what we were collecting. So we are only sharing county and date of birth with the CDC in terms of, personal identifiers, so that they have a sense of the age of the individual vaccinated and the general geographic location, but nothing else that would be identifiable. And the other information that's collected is because we have an immunization information system in Minnesota. And so immunization information on all vaccines goes into that, and that provides a record. Providers actually use that as part of their electronic health record. And so it includes that information on that patient. The goal is that, at least with these initial vaccines, that the second doses will be scheduled by the employer organization or the organization that's doing that initial vaccinating. But yes, in general, we're able to use the immunization information system to send out reminders and recalls. But at this point, we don't have a plan to be calling everyone about their second doses, just simply because we don't have the bandwidth. But we do have plans in place to address, making sure people do get the second dose scheduled and have the ability to know when that's going to happen. As for the cards, the intent is so that the individual has documentation. Obviously, this is an important vaccine, and so we want them to be able to have documentation that they have received it. The intent is not that it is used, as a means to gain access to anything. It's just simply so that they have that in their hands. They don't have to rely on reaching out to their healthcare provider to get access to that information.
Thank you. Next question comes from the line of Brian Bass from Minnesota Public Radio. Your line is open.
Hi there. Tomorrow will be 2 weeks since Thanksgiving. When will you know if the worried about surge in cases stemming from travel and gatherings occurred?
I think we've said that we would expect to see that impact showing up in the data starting this week, but we have also learned it can take up to a full 4 weeks before that effect is more visible to us. We hope and think we're getting some perhaps early signals that the increase that we might have expected from Thanksgiving, we hope, was moderated by people changing their plans, as difficult as that was. We're not seeing, at least in these immediate days here, we're seeing a fairly stable picture in terms of our cases, albeit at a high rate. But Chris, what would you add?
No, I agree that 2 weeks out is a little bit too early to be able to detect anything, but we are hoping, we do feel positive about the impact that the pause has had. And so we do hope that our expectations for kind of some bad news a number of weeks after Thanksgiving will actually be incorrect, because people did make changes in their plan. So yeah, I think that next week we should start to see some things, but what we found over time with 4th of July and Labor Day and all these large events is that it really is more 3 to 4 weeks before we see the true impact.
Thank you. Next question comes from the line of Paul Scott from Forum News Service. Your line is open.
Hi, thanks for taking my question. I'm wondering, how big are these groups? The first 1A phase, I'm assuming that's healthcare workers that face COVID patients as well as long-term care. Do you know how big that group is in Minnesota?
Yes, I mean, first of all, just so you're aware that the details of the allocation recommendations are on our website. And so I just, want to make sure that you're aware that it does go into a great deal more on the actual groups that are included in that, if that is of interest to you. So if we look at hospital staff across the state, that is about 163,000. So that would really be included in groups in 1A, first and second tier. The number of long-term care staff across the state is felt to be 130,000. So that would also be within, tier 1 and 2. EMS is 5,400. So if we look at total staff of the highest risk healthcare settings, it's about 298,400. Now that does not include the residents themselves. That does not include clinics and the many other healthcare settings that are included. So if you think about that, that's a fairly large number, and that doesn't even get us all the way through phase 1A. The estimate the estimate that we gave yesterday was about 500,000 for all of phase 1A.
Okay. And I apologize if this is on your website, but I'm just trying to make sure I understand this. So under these 3 phases, a person who's 80 with a heart condition but who lives at home, they come after someone who works in utilities?
The way that this is prioritized, and keep in mind that this is coming from the federal government, and that the decision making has been informed by ethical guidelines that were put forth by the National Academies of Science and incorporated into the Advisory Committee on Immunization Practices decisions, as well as the science of what we're seeing is who's at risk, the ethical considerations, and implementation. All of those 3 things are a part of the decision making. And so in the first priority group, that would mean that individuals in healthcare and in long-term care settings were prioritized. It looks now like 1B will be essential workers, and then 1C would be individuals who are 65 and older or who have underlying health conditions. But the vote on those next phases has not been made. And so that's just what we've heard, that's what's projected at this point.
Okay, thanks so much.
Thank you. Next question comes from the line of Glenn Holt from Star Tribune. Your line is open.
Hi, thank you. Chris, you mentioned the social and I'm just wondering how that works, how it actually will affect people. And as I heard you say it yesterday, it sounded as though areas that score high will get a slightly larger supply. But I'm wondering if public health will be proactively reaching out to people who might be more disenfranchised.
Sure. Thanks, Glenn. That's a great question. So as I mentioned yesterday, the Social Vulnerability Index is something that CDC has prepared. It takes 15 elements from the census information that's collected and uses those to identify census tracts and locations that are considered to be more vulnerable. And so it looks at, income and education, minority status, type of housing, access to vehicle. There's a range of different things that would impact a community's vulnerability. And what we've seen with those data are that communities that have a higher social vulnerability index have more quickly moved to be a COVID hotspot and have seen more severe consequences of COVID in those communities. And so our allocation work group looked at our decision making and evaluated what role that social vulnerability should play in vaccine allocation. And so in this first phase, which is very highly employer-based, the decision was that 85% of the vaccine would be allocated strictly on a pro rata allocation. So strictly based on, we've got 100 healthcare workers in our region and 100 long-term care residents. So strictly based on, people and need. And then 15% would be distributed based on social vulnerability index information in areas that were considered more vulnerable. Now, when the group talked about this, they acknowledged that in particular, this first phase is unique because it is both residence-based and workplace-based. And so that's partly why the proportion of vaccine based on that social vulnerability index was a little bit, lower, not real high, was because of the unique nature of the individuals to be vaccinated. But as we move into other phases of vaccination, where we're no longer focusing on an employee-employer-based situation, then yes, the intent is both that the proportion of vaccine that is allocated based on social vulnerability will be reevaluated, as well as the efforts that will be made to make sure that all populations have access to vaccine, recognize its value, hear from community leaders in their own community, talking to them about it. And I certainly don't want to give the impression that we won't be doing outreach even in this first phase, but because it is so focused on employment, it's a little bit of a different situation because people will be hearing about this more directly in their work setting.
Thank you. Next question comes from the line of Bill Werner from Minnesota News Network. Your line is open.
Oh, thank you. Chris, I think I want to follow up on a response that you gave to an earlier question. And we were talking about the 1B and 1C categories. You said that a vote on the next phases has not yet been made. Were you speaking of at the federal level? And then if so, do we have an idea how soon that would happen? And then after that, what is the timeline in terms of the Minnesota committee deciding the gradations within that? And another part of this question, I'll repeat some of it if you need, is then in that particular case, the essential workers category, has there been any preliminary determination on who might be included in that?
Okay, Bill, I wrote that down. So
it's a lot, but yeah, sorry, Chris, I would probably forget the first and second one. So please, I'll be happy to repeat.
Sure. So there has not yet been a determination for phase 1B and 1C, although, as we've indicated, there are leanings for that, but the vote has not taken place. We know that
that's the federal level, Chris, if I may, that's the federal level we're talking about. Yeah, okay, very good.
That's at the federal level. We know that, for instance, ACIP has scheduled a meeting for this Friday. That will be a meeting to discuss the decisions of the FDA on the Pfizer vaccine. And they also have a meeting scheduled after the FDA meets about the Moderna vaccine. Now, the decisions about prioritization are separate. And so my expectation is that when they get past voting on these two vaccines and providing us with the necessary guidance, that then they would take up conversations about the next phases. But the bottom line is that we are not in a place to be moving forward just simply because we don't have adequate vaccine for phase 1A. But I anticipate that they will begin that discussion shortly after the decisions are made about the vaccine. And having said that, they met on Tuesday of last week, and we had our advisory committee meeting on Friday. So we will work to bring that group together as soon as there's an ACIP determination. And given the complexities of the essential worker, it may be something that we start to have conversations about beforehand. But yes, that is going to be challenging because it's mind-boggling how many parts of our society are so absolutely necessary. and how many individuals play such important roles in their work. And it's so frustrating to be in a place where we're trying to parse out limited vaccine. It's really challenging, but that's kind of the plan. And we will certainly have our group get together as quickly as we can after we hear from ACIP.
May I just do a quick follow-up, Chris, and that is the determination on the category of essential workers, 1B, I guess it would be, right? Will the federal government determine which essential workers are included in that category, or is that a determination of the state committee? And you talked about just a little bit, has there been preliminary work done on that, on a list? Have you got, I don't know, a napkin list or something of who essential workers might be?
Yes, I mean,
That is today's COVID-19 briefing by state leaders. They reiterated the vaccine, which is expected to get FDA approval tomorrow, is one of the best things that we can do to get out of this pandemic. Pardon me. They also said it's safe and effective to take the vaccine. They said it will be free. The federal government will buy and distribute it. However, you may have to pay for a clinic visit to receive it. The health department expects those fees will be reimbursed through insurance. State leaders say they're also waiting for more guidance from the FDA before giving a recommendation for people with underlying health conditions. Once given the green light to distribute the vaccine, the state says it will do so through a rollout and access plan so the general public knows when it will be available for you to take. We'll have much more coming up on our evening newscast. The MDH briefing and the question and answer period will continue now on CBSN Minnesota. Stay with us here on WCCO and CBSN Minnesota for the very latest on the state's response to the pandemic.